mixed method statistical approaches to study personal predictors of self-injurious thoughts and behaviors, particularly in LGBTQIA plus populations. Olga, thank you for being here.
Thank you so much for having me, and thank you all for being here with us. Um, Dominic kind of touched on so many things that I was going to talk about, so I'm just going to pivot real quick and kind of reframe so that I can talk about some things that maybe Dominic didn't touch on as much, but there's lots of crossover in what we do. I also study suicidal thinking in real time, meaning that one of the biggest things that I do is I ask folks to download an application on their phone. And so, when they're out and about hanging out with people or at work or whatever's going on with them, they get these notifications. And we ask them in real time. How strong is your intent to die right now, for example? And we get a different aspects of suicidal thinking because there's so many different ways to experience suicidality. And then we also do things like try to understand, like, if on that given day, for example, you were told something really hurtful by a family member, or maybe you were exposed to some really intense anti-queer rhetoric. Like, what's the impact of that on your mental health and your suicidal thinking specifically in that moment? And so it kind of allows us to get a little bit more information beyond that kind of traditional way in which our field has thought about suicidality for a really long time, which is kind of like, either you have it or you don't have it. We'll ask one time and then we're done. Whereas in reality, we're learning that that's like really not true. And someone might wake up feeling okay. And then by the end of the night, feel really, really suicidal and hopeless. I do this work, for all the reasons that Dominique mentioned, insofar as this is a population that is really deeply understudied. And so we know that having a sexually diverse or a gender diverse identity is not a risk factor for suicidality. We know that actually there are these experiences that explain the relationship between being queer and then having really elevated suicidal thinking relative to other folks. But the research that we have is just kind of really scarce. Like, we don't have a lot of it. And so I think it's really important to try to understand these mechanisms better. I also do it because, to me, um, in this time that's increasingly more oppressive, like at a time when it's kind of like you sort of have to think about what you say and how you say things, I find it really empowering to be able to say things like, I'm a gender affirming therapist, and I know that that saves lives because we have data, we have numbers that we actually can't deny that tell us that this is the case. And so, to me, being able to fall back on something that's so undeniable is really important. And yeah, I feel honored to be able to contribute to that work in any kind of way. I don't want to emphasize again some of the things that Dominic touched on. So instead, I'll tell you this about some of the things I'm noticing in terms of the current climate. So in addition to researching the impact of discrimination, for example, on the LGBTQA community, I also am a DBT therapist, and I work at a Pride clinic. And something that I've noticed much more recently is that um, increasingly trans and gender nonconforming folks are having experiences, for example, like in a structural sense, wanting to get a new passport or wanting to fly somewhere and then having restrictions that make it really hard for them to be able to do those things. Delays, having to like out themselves when they really don't want to do that to a stranger. So these really kind of intense experiences that are also really inconsistent. Like there's a lot of chaos in terms of understanding what is and what isn't going to happen. So I'm seeing the impact both in terms of enacted discrimination, so folks being discriminated against and their mental health suffering, but I'm also seeing that the fear around like, can I actually try to make sense of this is really very understandably like incredibly destabilizing, and clinicians are also struggling with this because so many of our interventions are cognitive in nature, and we ask folks to kind of check the facts and try to understand like what's the likelihood of this, right? Like how likely is it that this fear is going to come to reality? And the truth of the matter is that to a large degree, we just don't know right now. And so that makes it really hard to use those interventions. So I'm seeing that impact, across both our patients and also providers, trying to figure out the best way to support them. And I'm happy to speak about that more, but I think I gotta pass it on. So thank you.
No, thank you so much, Olga. We appreciate it. And I definitely have a million questions about your personal experience in the clinic. I'm sure you've seen a lot so far. And I know you just touched on a little bit of it, but I think the work that you're doing is incredibly important, and I'd love to hear more. Next, we have Chelsea. Chelsea's a postdoctoral researcher with the Harvard School of Public Health. She uses causal inference methods to identify effective treatments for suicidal thoughts and behaviors in individuals with serious mental illness. Chelsea, thank you for being here.
Thank you. Okay, I made some slides, so I'm going to share my screen. Oh, 1 second. So many years into Zoom, and this part always still gets me. 1 sec. Okay. Okay, do you see my screen? Yeah, okay, thank you. Okay, hi everyone. I'm so excited to be here, and everyone's made such incredible points and also touched on things I was going to say. So being the last speaker means I'm just gonna say y'all are great, and thank you for the work you're doing and what you shared today about just these devastatingly high suicide rates and particular populations who are at risk, who are now going to potentially be at even more risk, as people were touching on, and the impact that these funding cuts and anti-DEI efforts have had. I've seen here at Harvard, because as folks might know, Harvard and Trump are in such a war right now. Everything has shifted in a very scary way, and we're banding together because community is so important. Nevertheless, we are struggling, and so I'm going to just chat about that. I put this figure up to show what people have described about the high suicide rates, and suicide in America has been increasing since about the year 2000, and it's been steadily increasing. It dipped a little in 2019, kept going up. It reached a record high in 2022 with nearly 50,000 suicide deaths. So, despite the efforts of many researchers and clinicians to understand and treat suicide, there is a steady uptick in America. And in other countries, it's actually decreasing a bit for most other countries. But in the US, there's many reasons beyond the two I put here that suicide, oops, sorry. Oh no, 1 sec. Okay, we're back. Okay, so There's many reasons why suicide is increasing. I just note two here as it's relevant to the funding and dissemination of treatment. So there is a disconnect between research and clinical practice. This has been a longstanding issue in our field. So even though we've made strides in suicide research and promising suicide treatments have been tested and developed, and uh, these are findings and treatments are not often translated to the clinics widely or soon. It takes on average like 12 years to disseminate treatments. So that's one reason. Another is that new approaches are needed and funding is very often required for some of these research approaches. And I'll talk about the grant I was on that has since been slashed. So these types of approaches that we've done for suicide research have been largely the same. We've looked at risk factors, and that's quite important, and it's valuable to understand suicide by looking at risk factors partially. And yet, that doesn't tell us much about prediction and these real-time risks that folks were describing. And so that's another thing we've identified as a limitation. And so in 2023, there was a really exciting launch of the Suicide Research and Prevention Center at Harvard and Massachusetts General Hospital. And this is a wonderful initiative that really brings people all over Boston together who are interested in suicide research and advocacy. We have folks with lived experience, we have folks with lawyers. It's bringing a whole group of people together to really just try to think about suicide in new ways and ways to treat it in new ways and hear each other. And so this has been wonderful. My mentor is the man on the left here, Matt Knock. Jordan Smoller is the co-director of this program. And so much research has been done now, and it's thanks to a grant, a $17 million grant from the National Institute of Mental Health. And also, they look very serious, these two guys, but they look like this when you interact with them. So they look serious in this picture, but they more often look like that. They're very approachable and wonderful to work with. And so then there was another launching that, and this is where I come in because I'm studying with these folks. So, psychologist Matt Knock and an epidemiologist Miguel Hernan walk into a bar. I don't know. I don't think they did that, but they do have a shared mission to prevent suicide. And so in 2023, alongside this exciting center, these two got a grant, a 5-year training program to bridge the gap between epidemiology and psychology for that new methods approach to suicide, really using new statistical techniques and frameworks to study, in this case, what's working or not for suicide treatments. So Matt said, "Hey, we should talk to these epidemiologists. They do these fancy statistics." And then Miguel said, "Hey, we should talk to the psychologists. They've studied this for so many years and treated suicide, so we should learn from them." And it's been a beautiful collaboration. We were 2 years in the program, and the mission I said is to really look at new ways to think about and treat and study suicide. And the collaborations have been immense. These two schools, Harvard Psych on the left, where I went to grad school, and Harvard Epidemiology, they're separated by a river, and that doesn't sound like too much, but Boston, you roundabouts and traffic, it's really hard to get to, and they don't talk to each other or take classes together, and now they do. I've taken many epidemiology courses, though I'm a psychologist, and epidemiologists have learned about mental health treatments and suicide specifically at Harvard Psych courses. So there's just been monthly meetings and wonderful chances to chat. And if anyone was wondering what the method from epidemiology is, it's called causal inference, which is a jargony way of just saying how one thing affects another. So there's this saying correlation isn't causation that we often learn in intro psych. And one example of that is this graph here, where a classic one, there's this striking association between ice cream sales and a shark attack, but that doesn't mean that shark attacks cause an increase in ice cream sales or vice versa. So to really look at causality requires this precise methodological framework and lots of statistical expertise, math. I don't know the math part, but I apply the statistics. But a lot of people got together to develop these techniques, and it's used in epidemiology, but not suicide. And we were doing that, and we're still doing our projects, although the funding has been slashed. We were told to still be able to complete what we've started. So thankfully, there's that. But one question that emerged that I'm still studying here is whether discontinuing lithium, which is a popular treatment for folks with bipolar disorder, and which folks with bipolar disorder often stop using for any number of reasons, side effects or feeling better. So nearly half of all bipolar patients who take lithium will stop it at some point. And we know lithium has a protective effect against suicidal thoughts and behaviors too. So we're asking, using these causal approaches, how does stopping a medication in this case affect suicidal thoughts and behaviors? I put too much detail, so I will skip over some of that. But one other thing we were looking at here is whether people with elevated suicide risk, how they respond to online mindfulness-based treatments. So the way we really execute all this is a lot of existing data from these hospitals, by the way, I should say. So both of these projects are with existing data. We also look at electronic health records. So it requires a large-scale collaboration effort and so much security, of course, because these are sensitive health data. So that's where the money comes in and is required to salary folks and to help pay our patients when we're collecting new data and keep everything going. And so for this finding here, what we're seeing is that people with heightened suicide risk at the start of an online-based treatment, which was conducted at Mass General Hospital and distributed online widely. So we had thousands of participants, and those with heightened suicide risk had less gains for different treatment targets we had here: well-being, social ability, stress. And so relative to those who don't have heightened suicide risk, we're seeing that they're not improving as much, those with risk. The next question is then why, and what is causing this different effect between those with and without heightened suicide risk? And so the causal inference techniques are one way to get at that. They weren't applied in this work, but these are the types of questions we're asking. And everyone on the panel before me already said one beautifully, how everything is being impacted in such a cascading way. And what's been keeping me afloat is community and the initiatives that are taking place, events like today. So thank you, Liz, for putting this on, and everyone for coming. I think that's so important right now. And I also want to relay, like, science is, of course, supposed to be self-correcting. I never want to claim that science is perfect, because by definition, we're supposed to keep improving with each project and as a system. So we want to reduce systemic bias, and that also makes for better research and reduces risk for our patients and participants and us alike. If we just feel a sense of belonging and have efforts like DEI initiatives, which I've been a part of as a first-gen queer gal from the Bronx. I've had so many programs like that I don't think I would have been at Harvard or in grad school without them. So it feels personal to me too. And coming from the Bronx, where there's so much strife and trauma, and I've lost friends to suicide, we know that the science isn't perfect, and that is why we need to keep improving. And to do that, we need the funding. And that allows us to strengthen these programs, bridge collaborations, collect more data, and do some of the awesome projects that the panelists described. So ultimately, this hurts. These cuts hurt our patients, and our patients have been, for me, describing it more to us, how they're being affected. And we are seeing how our patients who identify as LGBTQ are feeling, and our BIPOC patients, and it's immense, and it is amplifying their symptoms, including suicidal thoughts and behaviors. And like I said, it is a cascading impact. I lost my job. I'm doing a totally new thing. So even though I can still pursue the project, that's on my free time now, which I'm doing because I love the work, but now I'm focusing more on other stuff. I'm also interested in, luckily, with another team, but it totally shifted things for me. So people have lost their jobs, and our own mental health here at Harvard, the anxiety has skyrocketed. The vibes feel very different. Patients are having a harder time accessing care, which was already an issue, and promising treatments are being abandoned. Individualized treatments, like what Dominic was describing for individualized models, will be harder to understand. We've been trying to understand these for a while, and we've finally been making strides with technological advances, and now many of these projects have been cut. And I just think back, to end on a personal note, about the Bronx, because That's where I grew up, and that's what got me into this field, is seeing the intergenerational trauma and the pain. And when I found out that there's a field to study this and to become an expert in treating different ailments, it meant so much to me. And I've met and worked with so many wonderful people who are suicidal as patients, as colleagues, as friends, family, and it's so important for us to keep fighting. The mission lives on. These are two of my colleagues who were part of the training program with me, and we just deliberately wanted to smile when we, like, after mourning, when we found out that 90% of the funding at Harvard School of Public Health was cut. And it just gave us a sense of empowerment. So again, I want to emphasize community right now for all is so vital, however we may be able to get it while staying safe. And so, yeah, thank you all. That's it from me.
Oh, thank you, Chelsea. It's terrifying to hear what exactly is going on at Harvard, but I think, yeah, your perspective is really valuable. I love hearing the research that you're doing and how positive that you're staying and that you're able to continue working on the projects even though it's been you've been getting some pushback. And just again, I can't say it enough. Thank you all for sharing your work. You're all doing really incredible stuff. You're working on really complex projects, but you've broken it down in a really human way. And so I appreciate that. I think all of the viewers appreciate that. We've covered a lot of ground. I do want to open this up for a discussion in the last 15 minutes or so. This is a great time for anyone to drop in the chat or the Q&A, get a better understanding of who these scientists are, deeper dive into any of the topics that they very briefly gave an overview on. Again, any questions, comments, drop in the chat. I do have a few of my own. Some of these are very broad, some are a little more specific. One of the questions that I get, and Chelsea, this is actually you're probably best suited to answer this, but I'm curious to hear everyone's perspective on this. Whenever I tell people I am a suicide researcher, the first question I get is, why are suicide rates rising? And like, that is such a broad question. There's a million reasons. TED Talk format, can you give any type of answer? And especially you mentioned there's a discrepancy between US and other nations.
Yeah, it's so puzzling because there's such an array of factors at different levels. So again, like Dominic's project is looking at these different levels. So I think we've really started thinking about it in that way. Like there's the individual risk factors, which we focused a whole lot on, and then there's these societal norms and changes and political relate things that become political and changes, like the loss of the 988 LGBTQ specialty clinic. So the rise, there's been so many theories too, like to what extent is digital technology playing a role? And we're still understanding that with great centers specializing in that. But it's not fully clear. And I think that's why the T32 grant is the one I was on was so important because it was going to take existing treatments and reanalyze them because a lot of our analyses are based on averages. And so the causal inference approach allows us to look at things in a different way and see how, kind of estimate how people would have responded if they got a different treatment. We actually have ways to build alternative models of people. So I think these new approaches would be helpful, but it's not fully clear. But I'd say it really is a combination of the lag between research to clinic. The translation takes such a long time, loneliness increasing, and societal barriers to care and changes like the ones happening now, which is part of why I'm so concerned, because even outside of the funding cuts, just all the different things happening right now put these high risk people in a very vulnerable spot. So, but there's a lot more too. I didn't cover everything, so I don't know.
Yeah, I know it's a big question. If anyone else wants to touch on it. We have a couple of questions in the chat. Broadly, again, this can go to everybody. What made you all interested in suicide research specifically?
Sure, if that's okay. Um, a couple of different things. I was lucky enough and I had the privilege of being in graduate school at the time where there was a new faculty member starting who had just come out of Thomas Joiner's lab, who was one of the people who originated one of the awesome theories of suicide that I think Dominic was referencing earlier. Um, and so I had the privilege of learning about that and was really interested in it. The reason I didn't go into suicide research initially in graduate school is because it felt a little bit too close to home. I have lost three people that I love to suicide in my lifetime. Um, that's also, interestingly enough, the reason that I ended up going into suicide research, because once I became more sort of comfortable in my skin as a clinician, once I got more and more invested and interested in understanding trauma and how trauma can be effectively treated, I started to really see how critical an issue this was to explore and explore in depth in this specific population. So that's what it is for me. That's why it feels so important and so really truly personal for me. And I would love to hear for other people what draw you in.
I would definitely echo many of the things that that Dr. Davis or Maggie said. And I think two other things. I think one, it's like a really odd thing that that death is like the only thing that we know for certain, and it's also something that we never talk about. Like we'll talk about anything, but and I think that creates so much existential fear. Like we're literally like programming ourselves from the time that we're born to avoid talking about death, which I think makes it so hard to cope with it in any kind of way. And I think to me, suicide is like researching it, working with folks who are suffering from suicidal thoughts and behaviors is kind of one way to like really approach that and like approach that actually kind of pretty like more normal part of life than I think we all tend to pretend it is. Like so many people experience suicidal thoughts in some form, in some point in their life, and yet it's like so deeply stigmatized. And then also I think just how like it shows up across so many different mental health conditions. And also like sometimes there is no diagnosis, there is no, mental health um broadly speaking, and suicidality is still there. So yeah, I think some of those factors for me, for sure.
I can go next, I guess. So for me, growing up, it was sort of again similar to Maggie, a little bit close to home with some of these events. I think when I was in high school, suicide was sort of an annual occurrence for me with a friend. Anyone that I was close to was sort of like my year marker was okay, we're one down. And I think that during that time, when we're trying to figure out what am I going to study, what am I going to do, I realized that I had this very interesting way of thinking about suicide that really differed from those around me. I wasn't really interested in why this person ended up dying by suicide. I was more interested in like, what is this thing that was taking friends and family members and so on away from me? And how is this happening? Like, what is the process that unfolds and how do I intervene? Um, how do other folks in their lives intervene as well who are maybe not professionals in the field of psychology or something like that? And I think for me, that was sort of the roundabout way that I ended up here. I was an anthropology major in undergrad and did a lot of bioarchaeology and forensic anthropology and was like, I kind of want to understand like what people were like when they were alive and not necessarily just studying taphonomy and what happens to people after they die. And so that's sort of how I found my way into clinical psychology and focusing a lot on the suicide research aspects of it.
Thank you all for sharing. It's wonderful to reflect back on that journey, because there could be a lot of twists and turns in it too. So for me, I knew I wanted to study clinical psych and get a PhD. I did not know what a PhD was because, again, first generation college gal from the Bronx. So I really didn't know what it was, but I knew it trains you. And I like being trained as many years as needed to understand something. So I knew I wanted that. And I really noticed in the Bronx, again, a lot of emotion impairments. Like people would react very strongly. We were all in a space of like it's crowded, it's polluted, there's a lot of stressors and cortisol. And so it's hard to regulate our emotions, and we're not really taught it either. And so I was really interested in emotion regulation impairment, which happens to folks across different mental illnesses, and whether or not you have heightened suicidality. So, alongside that, the other thing that was interesting to me was identity and how we become a sense of self who acts different around different places. Because I was studying at these schools that are often very wealthy, and I would come home in the Bronx and act very different and speak different. So figuring that out for myself, like I knew those topics were interesting and relevant clinically. So I really approached grad school thinking, I'll focus. I don't know which mental illness in particular. These things are relevant for all. So I studied a few different mental illnesses, but it was really right before grad school. I was part of a study that it was an fMRI study, a neuroscience study at Columbia University, and I was someone who would see the patients, and these are patients with depression at Columbia, with or without suicide attempt history. And I was to collect 8 memories, upsetting memories from each patient. And that sounds not fun. We definitely stayed with the patients after and made sure that didn't activate anything because that was hard for the patients to do. And so I would collect these memories and I would hear in vivid detail some of the things that really centered around their attempt, methods used. And so it kind of, for me, because I did admittedly also have fear, like Olga said, we're in a culture that doesn't talk about death, and suicide can be scary. So without that project, I don't know if I would have landed here, but it was a series of different things because once I met these patients and heard their stories and about their attempts, I just couldn't look away. And I was like, I need to keep studying this in some way for the rest of my career. And so, yeah, it's been a journey.
Thank you all for sharing. There was another question. This is directed towards Chelsea. How do you think that the homeless commitment executive order will impact your research?
That is a wonderful question. And so I'm not just riffing without knowledge. I admittedly don't know the full details. So I don't, not to put anyone on the spot, but if anyone here might know, I just want to know I'm thinking about it correctly, the executive order.
Yeah, if the person who asked in the chat, if they want to add any more details. In the meantime, there was another question. We can circle back to that. The implications of veteran mental health and suicide prevention in the research that we all do, if at all. Anybody wants to comment?
Did anyone do their internship at the VA or at a VA? I was gonna say, Maggie, did you work with Tom?
No, no, I worked with Tracy Whitty.
Oh, okay. That makes sense.
Yeah,
Okay.
yeah.
Well,
Awesome.
anyway, you should talk about this. This is right up your alley.
Yeah, yeah. I got into a big part of what I've wanted to do and have always wanted to do is to help with and understand veteran suicide specifically and veterans' mental health. And veteran suicide is alarmingly common. Veteran PTSD developed especially post our most recent conflict, so the OEF, OIF, Iraq and Afghanistan conflicts. It's got a rate of something like 33%, which is unprecedented, extremely high. And people who develop PTSD are more likely to experience functional impairment, less likely to benefit from treatment, more likely to experience functional impairment, and more likely to die by suicide, related probably to all of those things. It's difficult to disentangle at a biological level, sort of neurobiological level, if and how it's different from civilian suicide, we know a couple of things. So we know the nature of trauma that somebody experiences probably affects what somebody experiences and the extent to which they might be at risk for suicide. For example, if somebody experiences a trauma and that trauma is interpersonal in nature, and by that I mean it's a trauma that has to do with another person, like an assault or something of that nature, you're more likely to experience really serious consequences like suicide for a number of reasons, in terms of the way that it affects the way that you think about things. Um, Military traumas, oftentimes it's not just one trauma, right? Oftentimes it has to do with your whole deployment. And a whole another sort of separate and additional part of this is military sexual trauma, which is a new thing that we were just really beginning to understand because women in the military and recognition of women in the military and how to treat effectively women in the armed services is very new. And I want to be really clear, military sexual trauma is not specific to women. Recognition of military sexual trauma, I think, has emerged in part because of the recognition of the importance of female veteran mental health care. That is uniquely tied to suicide as well. So I think the answer is we know there's increased risk. We don't totally understand why. We know some things like sleep, like increase in negative post-traumatic cognition. So these changes in the way that you feel about yourself and the world and other people and how safe you feel after a trauma are connected to suicide in unique ways. The good news is trauma-related therapies that we know are affected are specifically targeting some of those things that we know are linked to suicide risk. And I won't say bad, but the news we're working on is that there's a lot of other things that we don't understand. And that impulsive suicide and suicide attempts that are high lethality are much more common in veterans. So this is a population that I think we've got a long way to go. And there are some really good and really important resources being dedicated to that effort.
I will note, and I had mentioned this at the beginning of this webinar as well, federal researchers, which includes the Department of Veterans Affairs, but it goes, I think, across all federal research institutions, are currently prohibited from most research talks. So not able to engage in research talks. I will know I had reached out to several federal researchers in the suicide field for this webinar, and they all declined separately, explicitly saying that they are prohibited from giving talks right now. And they're prohibited from sharing their research more broadly. So this is a very stressful time. And again, it is for those experiencing suicidal thoughts. It is for researchers too. Yeah, it is a really challenging time. I do want to circle back though to Chelsea, just for the question that was directed towards you. If you have any thoughts.
Yeah, thank you. So I read up briefly to make sure I was updated, and to my understanding, this executive order is really trying to shift how we think about and treat and help people with who have homelessness. So for one, they're shifting away from housing first, and they're really emphasizing things like involuntary treatments and focusing less on resources and more on really separating homeless people from other people, just to be frank, in how I'm interpreting what they are trying to do. And so I think the effect of that on the kind of research we're doing with this grant is quite layered, actually. I won't yap on too much, but I was thinking about it in two ways. One, I mean, the homeless population is so at risk already. There are so many stressors there. There's isolation, there's the elements in safety that they have to worry about, financial strain. I mean, all of the stressors in one's life domain you could think of are often present among people who are homeless. So I think this is one example of an initiative that will target an already vulnerable population population for mental health difficulties and isolation from others and suicide. One of the reframings for this is, if I don't know exactly how the treatment structure will look, but if they do receive treatment, people who are homeless and have mental illness, if they receive good, sound treatments that are culturally informed and well-intended, then I think that then we'll have their data in our electronic health records, and then what we do is we de-identify that data, and we're able to finally look for that specific population. What are the effects of X treatment on their mental health, on their suicidal thoughts and behaviors? So the upside is, if there are shifts in treatment, hopefully it's for the better, then we will be able to look at how they're responding in a way we might not have before, because we have limited data on these populations.
Thank you again to all of you, and for everyone who joined and for the questions. What we've discussed tonight and what we've learned from all of the individual talks really highlight, I think, the importance of community coming together, ending division. And I'm just so appreciative that all of you joined and care enough about such an important topic. So we've heard what happens when research is defunded, not because it lacks merit, but because it dares to ask uncomfortable questions. This isn't about the politics of funding allocations. It's about the silencing of inquiry. Our speakers tonight and everyone who joined the conversation are evidence, though, that science matters. In such a divisive time, this group is demonstrating the importance of unity and our common humanity. This discussion really underscores the importance of suicide prevention, and I think reiterates that every life is worth the data, the funding, and the policy action it takes to save it. So whether you're here as a scientist, an advocate, or someone who's been directly impacted by suicide, you have a role to play in pushing back. I'm going to share my screen with some final steps before we wrap up. I know we're a little over time, so bear with me. So if you're able to, I really encourage everyone to write, speak out, organize, donate, testify, and insist on a future where science is trusted, public health research serves the public, all of it. Science matters for our community, and it's not supposed to be us scientists in our stuffy elitist labs doing this work that doesn't impact anybody. We're doing it for a reason, and we want to keep the doors of communication open. So we invite you to reach out, stay in touch, carry the conversation forward, share what you've learned, support the researchers and their science, and help us demand a future that values science over censorship, inclusion over erasure, and suicide prevention over division. I'm going to conclude with a few ways for you to take some action from here. First, share this webinar and the Stand Up for Science organization with a friend. I hope this has been a pleasant introduction to scientific research and psychological science, but again, this is only the beginning of what I hope becomes a partnership between the scientists and the people that science intends to serve. Next, reach out to your representatives. If you learned something today, I would urge you to contact your representatives, continue advocating for scientific funding. Here is the link. It's 5calls.org. If you go to that website, I listed a couple of bullet points here. They have tons more that you'll see on their site, but I think these three really resonate with some of the talks that you heard tonight. You can reach out directly to your representatives through this site. So you put in your zip code, it tells you who to reach out to about the things that matter to you. It gives you their contact information so you can reach out directly. I also want to note, it doesn't matter if you're in a red state or a blue state. Again, science is for everybody. Reach out to those representatives. I feel like I've heard either it doesn't matter because I'm in a blue state, they already are doing these things, or I'm in a red state and people don't care about science funding. Just reach out. And lastly, consider supporting one of these organizations directly, either through donations or volunteering your time. I'll leave these up on the screen for a moment. AFSP, the American Foundation for Suicide Prevention, and the Trevor Project are both really wonderful resources, but they are also only a couple of many resources that are available. Please take advantage of these and do what you can to help others. Thank you again, everyone, for joining tonight, and for all of our presenters for sharing their work. I appreciate it.
What a wonderful, wonderful teach-in, you guys. Thank you so, so much for this. And I'm not just saying that because I'm clinical psych and have a soft spot for you all, but this was really wonderful.
Thank you.
And we did finally get the YouTube up. So it starts a few minutes late, but we were able to live stream. And so if anybody wants to share this, it's available, it's out there. And yeah, everybody also watch our socials because we have some very exciting things dropping tomorrow morning. So keep an eye out about 12 hours from now. That's your sneak peek.
Thank you so much. I appreciate it. All right. Any last minute questions, comments, or anything before we wrap up?